Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter.
Hello and welcome everyone. My name is Renee Garrett and I am your SpeechTherapyPD.com podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEU. Here are the financial and non-financial disclosures. Rachael Silveira is a paid employee of a health system in Florida. She owns two companies, SLP Badge Buddies and Trach Talks, where she earns a salary for product sales and lectures. She receives an honorarium from SpeechTherapyPD.com for her podcast appearance. Her non-financial disclosure is that she's previously and is currently developing tracheostomy teams with her employer. However, she does not receive any extra compensation besides her salary. My financial disclosure is that I'm a paid employee of a private consulting firm in the Commonwealth of Virginia. As the host of Brainstorms, Functional Neuro Rehab for SLPs, and other webinars on SpeechTherapyPD.com, I do receive financial compensation. I'm also an adjunct instructor for both James Madison University and Old Dominion University. My non-financial disclosure is that I'm the secretary for the Communication Disorders Foundation of Virginia. Now, without further ado, we welcome our guest, Rachael Silveira, who is an ASHA credentialed and licensed speech-language pathologist currently working at a level 1 trauma and transplant hospital in Miami, where she specializes in dysphagia and communication disorders with diverse training in dysphagia management associated with respiratory compromised, artificial airways, and medically complex neurogenic populations. Rachael strives to be a lifelong student by earning yearly ACE awards, which are awards of continuing education. This recognition is in support of those who exceed their requirements of continuing education for their renewal cycle. She continually supports the SLP community by providing clinical mentorship, as well as providing support for medical SLP platforms to promote continued growth for SLPs. Rachael has made patient advocacy and improving overall patient quality of life a personal mission and goal. She has spearheaded robust, multidisciplinary tracheostomy teams in multiple facilities with a mission of providing exceptional patient care by utilizing standardized protocols to streamline care. In addition, Rachael has curated multiple avenues for education for SLPs, including a Badge Buddy series and an open collaborative called Trach Talks, which promotes tracheostomy evidence-based research in an accessible manner. As our field grows rapidly, Rachael focuses on continued efforts to improve medical SLP education through ongoing participation in national and international conference lectures, active research, and guest lectures at multiple universities and hospitals. Welcome, Rachael. Thank you so much for joining us.
Thank you. Thank you for that wonderful introduction. I'm really happy to be here and excited to be here.
Yeah, I'm excited to have you here. So we have a few participants tonight. If you all wouldn't mind just kind of sharing with us in the chat box what your work setting is, so we can kind of get an idea of who is working where. And while we're kind of waiting, Rachel, just so you kind of have, you probably know this already, but my background is inpatient rehab, LTAC, and acute care, as well as outpatient. So I'm like you. I spent a lot of time in the primarily medical based setting where we work a lot with this population. And interestingly enough, as a student, is sort of where it all started for me. My clinical instructor in my second off-campus placement we had a trach patient that was a permanent trach, and we didn't have respiratory therapy who was consistently coming to the facility. So I learned a ton just from that. And as scary as it was as a student, it wound up being really pivotal for me to learn more and to be, kind of gain confidence and a little bit more competency with my skill set as time went on. So how did you wind up getting involved with this population?
Yeah, as I saw some answers kind of roll in. So I actually started in the clinics or in a clinic and doing like some home health, pushing into schools as well as my CF year. But I knew I always kind of wanted to be in medical. My internships were done in an LTAC and a PPEC. So I kind of got both like pediatric and adults. And then we had a third rotation, a skilled nursing facility that had a trach and vent wing. So I think that that's where my love for trach and vent started, in this very unique wing hallway of about 10 rooms that were trach and vent patients in a sniff setting. So they weren't really LTAC yet, which would be long-term acute care. So I really got my hands wet, my feet wet around that time frame, and then picked up a PRN job at an LTAC where I kind of flourished my love for trach and vent. But I was still at the clinic. I was still working with pediatrics and children and language disorders. I just knew that I wanted to be in an acute care setting. So that's kind of how I just applied for my first hospital job. It was contracted, but it evolved into a full-time position. And I've been, in a hospital for 8 years since. But definitely kind of going off of what you mentioned, just being exposed to even a few trachs early in your career can really shape or be a pivotal turn to see if you like it or not, and just kind of pushing the envelope where it is scary and fearful, but also like, oh, this is great, I can do this, or I didn't know this existed. I didn't get a lot of trach education in school, so it was refreshing to kind of be exposed to it outside of school and still know that I could do it, and not like, oh, I don't know how to do this, I need to not do it. I had, help, and I had assistance, and I had a great mentor, so.
Yeah, I was very fortunate in that realm too. I had a really great mentor as a student. And then when I did my CF, we had a team of 3 full-time and 1 part-time person. So we had people to bounce ideas off of and learn off of, which was great. And then having an LTAC floor where I work, we also had respiratory rounds, which we started doing regularly. And it was just incredibly eye-opening, because I think, coming out of school, we sort of had this vision of what we think, everyone thinks that acute care is glamorous.
Yeah.
It's really not that glamorous.
It really is not.
But I think it's helpful to have those opportunities, like with respiratory rounds, because I started to think of my patients more holistically versus, like putting everything in a box. Like, this patient has airway problem, this patient has dysphagia, this patient has a language problem, this is a old, has head and neck cancer that occurred remotely. So it starts to make you think a little bit differently in the way that you're treating the patient. Was there any kind of background research that you sort of did, or just started, moving more into that realm of research and looking at what that population needed and what it looked like?
Yeah, absolutely. I mean, it kind of stemmed mostly from what my hospital needed, and I was just seeing major gaps in care. No one was treating these trach and vent patients. They were, as sad as it sounds, sent to the back hallway. They're mechanically ventilated and they're nourished via a PEG tube. So not a lot of critical thinking needed to be involved, and that's just the nature of it. They're stable and they could be sent out. So I found that as I started like evolving and doing literature reviews, I was finding that the concept of tracheostomy teams, or just, which we'll talk about later, speech's involvement with this population, is not newly researched. It's heavily researched. It's just kind of plugging and getting the correct articles and trying to find what works for your facility. So, if you know that the time to oral diet, or getting a patient on a PO diet, or functionally communicating is your goal, maybe those are the numbers that you want to target. So, articles that we were pulling, some from 2018, 2016, we're finding like implementations of these tracheostomy teams provided consistent referrals to speech language pathologists. So, if you're starting to pull articles saying, speech and trach, or speech therapist and trach team, there's a correlation there. Like there's something going on about our role as a speech language pathologist and how we can help this population. And as you dig deeper, you are seeing consistencies and decrease in days to that patient consuming their favorite meal, right? Rather a constriction of just a PO, a PEG tube feeding only, and not having anything orally. That is such a joy for these patients. We sometimes in acute care, and I know you could probably agree with me, is dysphagia. We're like, that's usually the first thing they order you for, is a dysphagia eval. And sometimes I feel like communication takes the back burner, but really with these trach patients, it takes like the front burner, because they can't advocate for themselves. They can't verbally communicate. The minute they get tracheostomized and usually a PEG at the same time, the hospital system, obviously for the right reasons to save their life, takes away their ability to communicate and takes away their ability to eat. So this patient is now sitting in bed with two of the basic human needs removed to save their life. Of course, it was necessary, but I think it's such a great role for speech language pathologists to put themselves in their shoes, and then also try to, I always say, get them back eating and talking as fast as you put that trach in, right? The minute they come in urgently for a trach or a PEG, we can work just as fast and efficiently. And the research points at that if we can get a consult sooner, we can get them eating sooner, we can get them talking sooner, and hopefully rid them or liberate them from this artificial airway.
Yeah, and the interesting thing, having worked in a hospital that sort of became evolved, that's probably the nicest, easiest way to describe it, because when I first started in acute care, I was PRN, so I covered every hospital wherever they had a need. So we have about 5 hospitals total, and it's anywhere from the level 1 trauma center, level 2 trauma center. Then we have 3 other sister hospitals that, provide a variety of care, from cardiac surgery to weight loss surgery to emergency care. It's sort of those 3 hospitals sort of run the gamut.
Yeah.
So when I started working exclusively at one place, I was in the very rural sort of a country hospital, where we saw a little bit of everything, but anything that was a trauma got sent out to the trauma hospital. We have what's called the Nightingale here, which is our helicopter emergency service that transfers patients that are, having like things like a brain bleed or something like that this particular hospital couldn't handle at the time.
Yeah.
And so as the years have gone by and the population has changed and the area has exhibited quite a huge bit of growth, things changed. But one of the things that they still continue to practice now is a lot of our trach patients and a lot of our vent patients were sedated at the same time. And so it made it very difficult and very challenging to get in there at that early stage, because some of the practices they were doing were quite different than when I was working over at the level 1 trauma center, where, people were getting off sedation a lot faster depending on what their needs were.
Yep.
And so do you see that? I know you're in Miami, so that's a little different, but has it been really setting dependent for you as well, based on the level of sedation and how safe it is for us to get in and start getting these communication? I'm like you, it's a little bit different.
Yeah.
Because people can communicate when they're sedated, but it's a little bit more of a challenge when people are sedated who aren't really awake and alert enough to do some safe PO trials or a safe instrumental exam when we're, not able to stay awake.
Yeah. No, I completely agree. I mean, fortunately enough, the 2 facilities that I've vested most of my time in were level 1 traumas. So we kept them, right? We got the patients that either were sent to us, or we were the center that, operated on them. We didn't have to really send them out, but I will say we had a big culture shift in my last facility, where exactly what you're saying, that sedation, no sedation vacations were happening, and automatic trach and pegs were placed at the same time in surgery. So we had a lot of work to do with the implementation of our tracheostomy team to kind of get buy-in. And I urge anyone who's listening who works in a hospital or even SNFs or LTACs or medical settings to really focus on the buy-in portion, because if you just kind of like 0 to 100 too fast and shove these concepts down surgeons' throats and doctors' throats, they're not going to take it like they're not going to take it, they're not going to receive it as well. Yeah. And because they're set in their ways, and at the end of the day, they are the ones performing the surgery. But the more we can provide our expertise and explain to them, if you give me my consult, we do post-op days 0 to 1. Passy Muir usually recommends anywhere from 24 to 48 hours prior to putting a PMV placement on. Percutaneous trachs, or the ones done at bedside versus in the operating room, can typically be putting a Passy Muir valve on in 24 hours, just due to like less bleeding, less risk of secretions, and they're lightly sedated versus an OR sedation. So getting that buy-in and kind of explaining to them what we can do in those first 24 hours was very heavy on education. Family member being at bedside, like you mentioned, if they're lightly sedated, they can still kind of functionally communicate either yes or no, eye blinking, or even moving their hands. A lot of the times they're putting their hands here and we're trying to tell them to not do that. Dysphagia usually is not the starting point on the first post-op day 1 or 2, but I think the thing to take away, and I will probably live my whole career saying, advocating for a speech consult the day after they get the trach or same day, because we lose them. People don't remember. I mean, I hope that we have such a great place in the hospital and we're like PT and OT, like those standing orders, but unfortunately we're not. And they get lost. They get lost in the system. And again, they're vented. They have a nutritional source. We'll consult speech when they're ready. Well, what is ready and when is ready? And are you actually going to consult me when you think they're ready? So 100%. It was a culture shift, but we saw it there. Too much sedation, not consulting speech, and we were missing like almost up to 50% of all trachs were not getting consulted, and they were just getting shipped off to LTACs. But as soon as we shifted that culture and did data collection, and actually we're hopefully publishing it by the end of the month, we saw that our percentage of consultations to speech went from something around the 50s, I don't know the exact number, all the way up to the 90s. And now in my new facility, we're seeing the same thing, about 40s going to about 80%. So we're seeing a major jump in our services being consulted, recommended, which then is ultimately only going to provide positive outcomes for the patient by putting us on caseload sooner.
Yeah, I mean, I have nothing to add to that because that's exactly. But the one thing I do want to reiterate that you said, the surgeons and even the physicians that are like your intensivists and your ICU docs, they definitely really appreciate the research-based.
Yep.
They appreciate the literature being brought up. If you can quote a study or provide a study or more than multiple studies, that you definitely get a lot more, what I'd say, street cred, right? They're going to have more of they give you more credit, and I think they will be more apt to listen to you when you come in from that realm of a knowledge-based and having that evidence-based, because that's how they're taught in medical school, is to look at the evidence. And if we're not providing that, we're just doing sort of like anecdotal stories, they don't really care about that. They don't care what Uncle Joe and that 3 did 4 years ago. They care about what you're offering that's beneficial and is going to improve outcomes for the patients.
Absolutely. Absolutely.
Looks like someone had a question. Would you please go through the recommended timeline or procedures again for SLP services?
Sure. Specific to a tracheostomy, I'm assuming would be, and not everyone follows this exact approach. Some people might be more conservative or more aggressive. I found myself to be more on the aggressive side. However, it hasn't steered me in the wrong direction at all. And we have to always use clinical judgment. We're not going to always, it's not black or white. Like acute care and even a medical is not black and white. So just because we say we recommend a swallow or a dysphagia or communication evaluation on post-op day 1 doesn't necessarily mean that we are conducting it. We have to use clinical education or clinical decision-making. But typically the process would be, like kind of piggybacking on what you're mentioning about rounds for like the respiratory rounds and everything. Speech had a very, very heavy presence in my last trauma facility. So we were actually in rounds with the intubated patients, and we would know when they were going to get trached. So it
Yeah.
can start as early as an intubation transferring into a trach, and you'll know about it, or maybe you don't find out about it until the person's actually trached. But I would urge you to join a rounds, whether it be the neuro ICU or trauma ICU. We're having a huge pulmonary population, our medical ICU. So you're kind of aware, like, oh, that patient's been intubated for almost 17 days. The trache's coming down the line, and you can start mentally preparing for what instrumentation or procedures are going to need to be doing. But you'll get your order post-op day 1. Speech goes in to do whatever their eval is going to be, education to family, assessment of the tracheostomy. Maybe they're awake alert. You're going to try digital occlusion or a passing mirror valve, PO trials if they're awake and alert, if you want to order instrumentation. And then timeline related to tracheostomy is very particular and tricky, but a lot of our surgeons operate off of our ear, nose, and throat team, our otolaryngologist team, who are the specialists in airway. So typically a trach change can happen anywhere from 3 to 5 days after the trach has been placed. So if speech is already on the case and your patient's flying solo, not mechanically ventilated, and you're already working with them post-op day 2, post-op day 3, you can already start expecting in your recommendations or with your team to start maybe downsizing that tracheostomy from that larger size to a smaller size to a cuffless. You can start working on functional communication with the speaking valve, getting them down for an MBS or a FEES, then working on capping trials, and then decannulation. So the timeline can be 3 to 5 days or a week to finish this whole span, or it could be months depending on the patient's critical illness. But I just urge you, get in there as soon as you can and advocate for this population and show them the literature. I have tons and tons of articles from 2017, from 2016, and it's been heavily researched that speech's involvement, just alone from our study, showed that patients are 6 times more likely to receive a speech consultation when there's an established tracheostomy team. So just that statistic alone, you can explain to your surgeons and your doctors and your medical personnel that, hey, even if we don't have a full team established, or maybe just a doctor and an NP, if we get these consults rolling in, these patients are going to be 6 times more likely to be seen by us and promote effective outcomes, positive outcomes, increased oral intake, and increased communication just from us seeing them and kind of doing our due diligence. Hope that answers.
Yeah, no, that was great. And I think a lot of times when, even like with nursing, like especially new grad nurses who come out of post-pandemic education where their clinicals were online and they didn't need a lot of hands-on, but even still some of the nurses that did have hands-on clinical education, it's an opportunity for us, if we are competent and have sought out extra training and have worked with respiratory therapy and worked with the otolaryngologist, it's an opportunity for us to also help educate the nurses. Because one of the things I know in our facility, when and I don't work there anymore, but when I did, was that some of the nurses who didn't have experience were a little intimidated by, tracheostomy for sure, but definitely ventilator. And this was not in the ICU. What happened was during the pandemic, they converted part of our step down unit to handle this intermediary between a true step down patient and a true ICU patient because of the needs of the pandemic and having more patients on ventilators and on having tracheostomies placed. And so what happened is they took nurses who may not have been well versed and experienced in this area, and they're giving them trach patients, because sort of like how a lot of SLPs wind up being sort of generalized in care, because you can be a dysphagia specialist, but if you're working in an acute care facility, you're going to see anything from grandpa stumped his toe and had his toe removed, and now he's got post-op cognitive decline, to aphasia from a stroke, to dysphagia, to a head and neck cancer patient who has a new challenge, or Parkinson's, or we really see just a wide variety. And it is difficult when you're a newer or less seasoned clinician to have that experience, but we have an opportunity to provide that education to our teammates And some people are like, really? We help with nurses? Well, yeah, because in acute care, I always say nurses are our best friend.
Mhm.
We get a lot of good information from the nursing staff. They're there when we're not there. We're not there for 12-hour shift most of the time. I know I did like 10-hour shifts early on, but I don't do that anymore. I don't have that kind of stamina.
Yeah, that's long. That's a long shift. I'm after 8 hours. My husband does 10 hours, but I'm like, he likes the extra day off. But 10 hours is a lot. So I can only imagine 12-hour shifts. Yeah.
Right? Yeah, no kidding. But I think it's an opportunity for us to that's another way for us to get a buy-in and an in with the staff is to help educate and provide what we bring to the table to these other disciplines who aren't necessarily physicians, because then when the physician's asking the nurse for information about the patient, they're also sort of tooting your horn as well, and you're
Yeah.
getting more buy-in through that route, because it's I think it's more of a level playing field
Agreed.
for us in that way.
Yeah. And kind of piggybacking off of that, like for that buy-in component slash education, I mean, I was such a surprise, and my surgeons will say to this day that they didn't know half of the stuff that we can do. So I've created like binders of like
Mhm.
research related to speech, communication, dysphagia, like capping. And they were like, you can do what on a ventilator, or you can work with them and do what, like, so it's just so interesting, like, because they're so limited in their education, like you said, nursing, their training, and surgeons, they focus on the insertion of the tracheostomy and when it's coming out slash management to like the most bare minimum and in the most respected way possible. They don't think about all the in between that we do. So really, I have never come across anyone who has been defensive or upset with me providing information, as long as we do it in like a tactful way and
Mhm.
polite. They're more than happy to listen and kind of like understand our role a little bit better. And then it's kind of nice to see that flourish, like you said, spread to nursing, spread to NPs, even residents. Like if you can teach a resident early on in their career a speech language pathologist role, we used to give resident lectures and the attendings were like, it's mandatory, you have to go. So I think about all these, PG1s and first years and even like medical interns, you're getting them at the entry level. So that's something that
Mhm.
they're going to take on for their next few years. And then they're going to teach to their residents and their students and etc. So it's this revolving door. And like, I think it's so rewarding to show them what we do and then actually them see the patient communicate and see the trach patient eating on the vent. Like it's very rewarding.
Yeah, yeah. And if you're in an hospital with a progressive care unit, a lot of times you will get long-term ventilated patients who are, they're going to be on the vent for the rest of their life, and they're eating at home.
Yeah.
They're eating in their facility. They've been eating for years and they've been fine. And that's one where I think people get nervous if they haven't ever worked with that population, or like the physicians will get nervous if they don't know the patient's background and they're like, oh my gosh, we got to get speech, which is also fine.
Yeah.
But it does give us an opportunity to, like you said, in a tactful way. And I find that, if you say to someone, hey, do you need help with that? Or how can I help you? How can I support you? Usually they're like, oh my gosh, yeah, absolutely.
Yeah.
Because there's a lot of people who don't even realize, like, yonk hour suctioning, that tubing and that yonk hour should not be sitting there at the bedside for a week.
Yeah.
If it's looking funky, change it out.
Yeah.
There's a whole
Yeah.
supply room
Yeah.
with all the things. Go
Very
get one
true.
and then change it out.
Oh my goodness.
So what would you say sort of moved you from being an SLP who really loved this population into trying to be more in the realm of the team development aspect? How did you kind of get involved with that and kind of lead us in that direction?
Yeah, absolutely. Again, shout out to my old facility, but it was I worked in a great hospital that allowed you the opportunities to kind of implement projects, and that might be your facility might be that, or maybe you have a really good, strong support system. So we had a lot of good involvement from our attendings. And again, like finding those gaps. So like I talked to my husband, he's a physical therapist and he's on the neuro floor, and he found a gap that he wanted to like really educate nursing and kind of strive for excellence in this specific like niche. So he did his own literature review and found kind of what he wanted to study. And similar to we're both like at the table studying, we found articles that were pertinent to how to improve. Like, so quality improvement is a huge thing in hospital systems, in LTACs and SNFs, rehab hospitals, any way you can improve the way that patients are managed and improve outcomes. So I found a staple article by Bedwell et al. 2019. It's a company that is called the Global Tracheostomy Collaborative. So they wrote literature basically talking about drivers for improvement, right? It's specific to tracheostomies. And I'm like, this is great, because this is like a cookie cutter, like follow these instructions, and this will help you. So I kind of like really dove into that article, and it talked about implementing rounds, standardizing protocols, kind of all the things that we always think about when we're seeing patients, but you're like, how can I actually do this? So it talks about like incorporating different components. And this is what I've done in both facilities, and it's worked. So we know that and they've researched it. So this is kind of like try and true like methods that will work. So like a systematic education program, a systematic round program, standardizing your protocols, making sure they're up to date, using evidence-based practice, involving your patients, involving your family members in the process, and then data collection. So I think that if you're going to start anywhere before you implement different drivers into your QI or quality improvement project, you need some sort of data. And that was, I didn't think I was going to like data in the beginning. And I'm like, oh my gosh, numbers and patients. And I would spend hours at work kind of like tracking change, but that's really the only way that you're going to drive it home or show them. Like, let's just give an example. Like, you want to decrease tube feeds on your trach patients, or maybe it's your neuro floor, right? Because I know this is like neuro rehab. Your neurological patients that have strokes, TBIs, and cranies, you're seeing an increase in tube feeds, and you really want to manage or assess that. You need to get the numbers, right? You need to find out how many patients are on tube feeds, how many days are on tube feeds, the cost of daily tube feeds, and then devise a plan, whether it's rounding, standardized protocoling, including education, to then say, like, I'm going to do X, Y, and Z, and then I'm going to collect data again at the end and see if this works. So this company or this program development found that their specific approaches were utilized in multiple tracheostomy teams throughout the United States and globally, and they were successful. They improved outcomes. They reached broad institutions and facilities, and they published research and educational resources. So I kind of grasped onto that and implemented it at my facility, and then kind of did the same thing, track the data. We found significant improvement, and that kind of flourished. And then they were like, oh, this is actually working. What other floors can we do it on? Like, we did it on trauma, then we went to medical ICU. And now in the facility I'm working on has like over 10 ICUs. So cardiac, trauma, pulm, oral maxillary facial. So it's, once you can drive it home in one population, you can probably branch it out to other facilities in whatever project you are endeavoring on. And if it is a trach team, this is a great paper, a beautiful paper. If you Google the Global Tracheostomy Collaborative, Bedwell 2019, you'll find it. It's a great paper.
Yeah. Well, and I think, it brings up two things for me. One is one of the other crucial members of the team for me was always our registered dietitians, because those were the people that would say, they a lot of times will have the data that you need as far as, is this patient on a bolus feed? Is it a continuous feed? What's the flow rate? Are they going to decrease that? Are they increasing it because the patient's losing weight? And again, when you're looking at things holistically, it's important to understand how that works. Because again, we don't get a lot of this in our education program for our masters. And so when you start to realize, when you're doing rounds and people are talking about wound care, and I'm losing my
ulcers,
pressure ulcers.
Yeah.
Yeah. We're talking about that, and we're thinking, what the heck does that have to do with me? I can remember being a newer grad and being like, okay.
Yeah.
And then I realized,
it's not like swallowing or speech. Exactly.
Yeah. Then when I started getting the holistic picture of the patient and understanding that crucial role that nutrition plays, and that, the neck bones connected to the stomach, but I'm making that up. Just trying to be funny. But everything is so connected, and I think we lose sight of that sometimes when we're trying to figure out our role in even if you're not a new clinician or less seasoned, but maybe you've changed arenas and you've gone from one setting to another. It's really important for you to realize at the beginning that we're looking at the holistic piece of the patient and how all these things interplay and connect. And then the other thing is, how do you work around, or how did you work around productivity? Because productivity is always the elephant in the room. And I know for me, when I worked in inpatient rehab, it wasn't we could do a lot more projects and things like that were more QI driven versus being in acute care when I was the only SLP,
Yeah.
or we had one part-time and one PRN. So that made it a little bit of a challenge when it came to productivity to implement new things, especially when you had old guard people in manager roles who that's what they wanted to see was productivity. They didn't really care about all your other stuff you wanted to do.
Are you taking advantage of our new amazing feature? The Certificate Tracker. The free CE Tracker allows you to keep track of all of your CEUs, whether they are earned with us at speechtherapypd.com or through another provider. Simply upload your certificate to your registered account and you're all set. So come join the fastest growing CE provider, speechtherapypd.com.
It's true. No, and I mean, I won't sugarcoat it. It was extra hours. I was hourly at my last facility, and I always would clock out, and everyone's like, "You're crazy. You should be clocked in for this." And I'm like, "They're not going to pay me for this." So it kind of stemmed from it just wanting really to be my passion project. I would find ways in my lunch break. All my coworkers were like, there she is, data collecting, or if I had time in between patients. Luckily, I was housed up on the trauma floor where we were doing this protocolization. So those patients that I was typically seeing were the ones that were in the study / in this implementation. So it kind of flowed very nicely. And then I had a lot of support from administration and the surgeons. So not that they gave me more time to do things, it just, when we had meetings, it flowed well. We had great minutes and agendas. And when we wanted a project completed or fulfilled, to create a brochure or create an order set, those things, we didn't really have a lot of hiccups. So I will say I was fortunate in that aspect. In this newer facility, it's much larger, like 3 times the size, a lot of red tape. Productivity is obviously still a concern, but again, a very supportive group, very supportive administration, where they can see that even just in a short little bit of time, change is occurring. If you think about it, it's increasing what's the word I'm looking for? My consultative rate. So we're getting more business by kind of promoting this. And I know that could be scary to some therapists, like, oh, we're going to have too many consults, but it's as good. We're helping more patients. It could even run the possibility of them wanting to hire a new speech language pathologist. We're all going to be productive because we're going to have enough patients to see. Patients are going to be on oral diets sooner. We're helping the hospital decrease costs and length of stay. So I really haven't had too much difficulty with people saying like, no, you can't do this, but I still need to be productive. I still need to see my patients for the day. And then whatever time I have, instead of going to grab a coffee or, leaving early for the day, like I'll use that time to sit and, and I can write in my productivity. I spent 30 minutes discussing with X, Y, and Z doctors or doing a research about rebuttal or something. So I would say just, run it by your management, let them know what you're doing or what you're interested in doing so that they can kind of see your light and see your passion. I really haven't had any difficulty with people telling you no. When they see that you're passionate about something and it's going to help their patients or their hospital in return, that's usually a very good sign for them to allow you to do it. So.
Yeah, that's a great point too, of being able to have more consults so the reimbursement is higher, and then also having the opportunity to hire more people to provide more services. And having worked in a larger hospital and in a smaller one in the same health system, I think the difference was in the smaller, our caseload numbers varied so much, it became a lot more challenging. Like the fees program, to implement that took almost 5 years of me banging my head against a wall.
I can imagine.
But
I can imagine.
yeah, but I did have a supportive manager, and she was willing to. She was very happy to get the legwork piece that I got when I did my fees training 400 years ago. We had a lot of supportive documentation that was provided as part of that training, and so having that and then updating the research articles was very helpful, because once that piece was in place, the vice president of finance for the hospital, all of a sudden, with that being in the capital budget for 4 years, all of a sudden he was like, oh, now I get it. And we just had to have the right people in place.
Yeah.
Because again, the hospital is in it to make money, and I get that. But, when it comes to team development and those quality improvement things, it's helpful to have the right people that are at least willing to listen. But when you come armed with, like you said, a binder or several articles, they can say no, but they can also be like, oh, well,
Yeah.
maybe I should consider this because this is actually a thing that I need
Yeah.
to be aware of.
Yeah, it's like the passion's like contagious. Like I made like a couple binders. They're like, can you make a couple more of these? And I'm like, say less. Whatever you need me to do. I had like all my articles spread out. Like it really was like infectious and contagious. Like everyone started, oh, we have a tray. Can you do an eval? Like it just everyone was super excited. And I hope every population's like that. Like, oh, we have a new post-op cranny. Like, can you work with them? It's just I feel like some populations get more like attention than others. We have stroke protocols, right? Where every patient that's a stroke receives a speech consult, or the cardiac population is becoming up and coming, like, with all this literature coming out of how prevalent dysphagia is, or, dementia, and, doing specific cog screeners and such. But I feel like the trach population just got the short end of the stick. So I'm kind of happy. I'm really happy to see a lot more focus. And then that kind of like, I guess, ties into our question about like our involvement with this role or with this population, and how it's not so new, but I definitely feel like in the last 5 years, or maybe even 10, 5 mostly, we've just gotten a lot more push, and just we're a hot commodity when it comes to trach patients. And I'm happy to see that because they need us. They really do.
They really do. And I think the earlier, definitely the better, as long as the other medical challenges are not preventative. Oftentimes what we see is people with multiple surgeries or need for a follow-up surgery for a different reason, not necessarily for the tracheostomy or the PEG tube.
Yeah.
And that sometimes is a barrier. We have another, the website that you mentioned, www.globaltrach.org. I believe that's correct.
Yeah. Yeah, that's it. It's great. That's a great resource. I don't have any affiliation with them, but I have worked closely with a lot of individuals from there, and they have a great conference coming up in November. But they have like portals within that website, great for your patients to use to educate and watch webinars. It's a great resource. So yeah, check it out.
Yeah, and I think and I'm not a paid sponsorship or anything like that, but Passy Mirror too, for me,
Yes.
early on, and even now, they still continue to offer free webinars that are very helpful, and they're not always provided by an SLP. Sometimes it's from a respiratory therapy standpoint, which is to me super helpful because you get both sides of the coin, but it still counts as CEUs for us. And so that's, I think, for people who are looking to gain competency or at least more knowledge, I think that's helpful, because I know that, even when I worked at outpatient, we had a pediatric clinic, and there were times when you'll get a younger kid with a trach too. And so again, not everyone is versed in that.
Yeah.
But in outpatient world, once you get them, they typically have had the trach for a little bit.
Yeah.
And so they're typically managed, they're doing okay at home. A lot of times they do have a speaking valve in place that they're using, or even like AAC involvement. So there's a lot of really positive things that we see come out of that, no matter what the age of the patient is.
Yeah, I've been seeing too that like there's actual literature that's showing that we're underutilized in the acute care setting. So that like we are so integral in the rehabilitation process that we can help with, downsizing the trach, getting them on oral diet and communication, which we know are two facets of our discipline. But even like they look to us now, and there's a lot of literature coming out about the use of fiber optic swallow evaluations and flexible endoscopic swallow evaluations for the use of decannulation. So to me, when I used to work in outpatient setting, I would always wonder why these trachs would come to me with like a size 8 cuffed trach, and they've been home for like 3 years. And I'm like, why do you have this huge trach in you? Like, and it's not that the system failed them. It's just that maybe the person wasn't equipped, or the doctor wasn't aware that speech could provide this level of care, this level of management to assist with speech communication and optimizing. I always see it as we see them through the entire journey of their tracheostomy. Although we are not the people taking the trach out and putting it in, we play such a huge role in, yes, doctor, the patient's been communicating all day, wearing the passing mirror valve during all waking hours, on a full diet. Do they have any other surgeries left? Are they breathing well on their own? Can we maybe start talking about maybe removing this trach? And it frees them up, it liberates them. And that's the first question most trach patients ask me when I see them: when can I eat? when can I talk and when can I get this thing out? So I always make that my goal. I mean, there's obviously the chronic trachs, the long-term, the quadriplegics, or the really severe head and neck cancer trachs. But for the most part, I would say more than almost half of my trachs that I work with, our end goal is to get the trach out, and they do very well. So I think that it's great that we can see more of this in the acute care setting, give them a better quality of life so that they can leave here and go home or to a rehab facility and not just only be sentenced or sent to an LTAC when there's other options for them, right? We want to set them up for success and the best ability and equip ourselves and our toolbox to make sure that we did everything possible that for that patient, if you had to leave with a trach, they had to leave with a trach, but at least we tried and we did everything. We got that consult and we did our due diligence.
Yeah, and it's not like a lot of the ones where we get it the day that they're already discharging or the day before, and everybody wants you to jump through 47 hoops. And it's a challenge because especially if we're going to plan on doing an instrumental exam, fees makes it a little easier depending on the patient, because we can typically do that at bedside. But if it's a modified barium swallow that's needed, or that's what the doctor orders, sometimes that's challenging to coordinate with radiology and transport and getting the patient, with their ICU nurse down to radiology, and having all these moving parts that we don't have. We like to have, I would love to have control over that.
Yeah,
And you
I
can
agree.
lay the best plan, and then it all can, it could either go really well or it could go right straight on in the toilet. So.
Yeah. I used to love when they would say, the patient's leaving at 4 p.m. today. Can you do an eval? And I'm like, guys, we've been over this. Like, please consult us sooner. But we get it done. We have disposable fees at our facility. We have AMBUs. So we just like roll up there, we find a bronc tower and we'll fees them. But it's like, please don't put this stress on me. Like, we have a systematic, and that's why trach teams are becoming such an up and coming thing, because it protocolizes, it standardizes it. And yes, not everything's black and white, but you definitely have a more systematic way about going through things. And you're already going to get your speech consult post-op day 1. So you have a plethora of days to work with this patient and organize your instrumental, rather than them forgetting that we even exist and we can help this patient until they're leaving in 10 hours. So literally, that's what happens.
Transport's set for 2:00. It's now 10 because rounds just ended. Kid you.
You're like, yes, I can. And I'm doing it because I love this patient and I want to help them. But that's a lot of stress on me to do in 4 hours, right?
Right. Yeah, you have to call in a lot of favors and
Yes.
put out a lot of fires.
Yeah.
What would you say? I think we've done a good job talking about the benefits. What would you say some of the bigger challenges are for the development of tracheostomy teams?
Yeah, no, this is great. I would say like the biggest pitfalls that others have told me when we've had like conversations, and some difficulty that I've had, like hurdles, I would say, they're not really like blocks in the road or anything, we were able to push through, would be finding like the right team. So finding, like you said, the right people who are going to support you. And sometimes it always isn't like the first ones out the gate. Sometimes you have to play around with it and change the members of the team. So we have champion surgeons, we have a champion respiratory therapist, we have a nurse practitioner from each discipline that, will come to meetings. And sometimes they just fade out and they fizzle and they no longer have that passion or their drive. And it just becomes like another job for them. And I understand maybe they have too much on their plate, and that's okay. But like, relinquish your duty or let us know that you're not invested in this anymore, because then I can find someone who is invested in it to really develop and implement protocols, because it's a team effort. I would say openness, the change is huge too. So like they say, you can't teach an old dog, a new dog, old tricks, or old dog, new tricks. That just because something was always done the same way, and in these big facilities where you're working with surgeons and doctors who have been doing this for 30, 40 years, or even sometimes 60 years, 4 times my time, tons of years of experience, they want to keep it the same way and they don't want to rock the boat. But I always am like, in the most polite way, just because it was always done that way doesn't mean that that's the correct way to do it. Would you be open to me kind of showing you some literature, some research about like how we can improve our processes, not necessarily like toss and throw away the old processes, because that is kind of disrespectful and probably a blow to their ego, and it probably bothers them that people want to change how they practice. But medicine's evolving. Things are changing, so our practices should too. And why should the patient suffer or be at the mercy of old practice when they can go down the street to a different hospital and receive, all the therapists like working at the top of their license versus the complacency over across the street. So definitely change, finding the right people, and then I think creating a learning environment. So like I always go back to, it's exhausting and I come home exhausted and I usually just want to like sit and watch TV because we pour our like passion and energy into all our patients, but it truly is contagious and infectious. So creating that learning environment, never putting people down for like not knowing something, making it learning and fun and just kind of like, oh, you're on the right track, but we're going to go this way, or that was a great attempt, but really like we always deflate the cuff when we put the passing mirror valve on. I never want to like, yell at anyone or tell them they're wrong because people don't really learn well in that environment. So
Mm-hmm.
I would say that those were obstacles and hurdles slash kind of things that I had to work through internally myself. I like to teach, but sometimes it can come off as, oh, like this person's a know-it-all, but really I'm just trying to share everything that's in my head and like put it into your brain so that you can spread the knowledge too.
Yeah, and that's part of being on the multidisciplinary team. I think is being willing and open-minded to learn from other people. And one thing we sort of didn't touch on, but I wanted to ask you, just based on our audience and not knowing everyone's work setting, who would you say are the crucial members of a tracheostomy team?
Oh yeah, that's a great question. So as part of like literature review and on the global tracheostomy page, different facilities piloted different teams. So like one came out of Johns Hopkins, one came out of an Australia hospital called the TRAMS model, and they kind of played with like who their integral members were going to be. There was always a speech language pathologist. So that's a given. That's us on our soapbox. And I think that in one study, they were actually considered support staff, but in all the other studies, they were core members. So I would say from experience and at least the two teams that we've developed, you definitely need surgeons. So you need like someone who is placing the trach, whether it be a general surgeon who's taking or assuming the responsibility of like kind of understanding how all the other disciplines work. So if you're in a facility with a lot of service lines, trauma, pulmonary, medical, burn, you need someone who's either been there a while or just kind of well versed and kind of friendly with all the other surgeons so they can help you manage and create protocols. You definitely need an NP or a PA. So like when that surgeon's not around or that intensivist is not around, that's the right-hand person, woman or man. They are the ones placing the orders. They are the ones that you're probably going to talk to on the phone if you can't find the surgeon because they're in the OR. You need a respiratory therapist because I think without them, the passing mirror inline and on the vent and those like capturing 90% of these consults are the vented patients. So you definitely need respiratory, you need speech. Those are your four people right there. And then you can play with dietitian, you can play with social work is pretty crucial because they're like the next dispo. And then we'd have like consultative pulmonologist, consultative ENT for like complicated tracheostomies, but you also could have a surgeon from each discipline. So a trauma, a burn, an OMFS, a general surge, a medical ICU, a pulm, but surgeon, NPPA, speech language pathologist, and RT are your big people. And
Yeah.
a nurse manager or a nurse leader.
Yeah, and I think ideally, that if you can get someone that's maybe not the unit manager, because sometimes they move into more the realm of management of people versus patient care.
Yeah.
I think it's helpful to have maybe like the charge nurse or the shift leader or whatever it's called at different facilities, because I think those people tend to be a little bit more hands-on and are more participating in the active rounds every day versus like I know at our hospital system, when they had the unit manager, they really started moving towards management style meetings for different units and stuff like that. They weren't always, unless there was a problem with a patient, and then they became involved, which is understandable from like a customer service perspective. But
or like a clinical nurse educator. A lot of
yeah,
facilities have those now, and those are like beautiful because that's their sole purpose and their job is to educate the nurses coming in, and you can kind of like give them all your information, give them your notebook and your binder of research, educate them, and then they spread it. It's great. Like they do the work for you, so it's awesome.
well, and I know when I worked in inpatient rehab, we actually were part of the education team and the training for new nurses and even the student nurses that would come in and do clinicals, we did a whole little spiel on dysphagia and communication. And it was not anything that was lengthy. It was like 20 minutes. So it was a very basic thing, but I think that's also important and could be a part of the initial team component, because you're not only educating patients and families, but you're definitely educating other staff. So yeah, I think that's a really crucial piece, because for me, I just feel like community education, and I say this a lot, people probably get sick of me saying it, but community education is still so lacking.
Yeah.
And to be in 2024 and I'm still seeing some of the same things and staff and mindsets of how we treat trach patients and mindsets of thickened liquids. Let's just give them nectar because it's better without anything. And you're just like, oh my God.
Yeah, it's true.
It's hard to change those, like you said, those old mindsets. But if you come in with the right approach and you have a good rapport with those staff members already, I think they're more likely to listen to you and be a little bit more receptive.
Yeah.
I worked with this one internal med doc, and he would do that on the weekend. He always say stuff like, well, I'd placed the order, but I didn't know if you or anybody else was coming in. And I'm like, really? You see speech every weekend. We're here all the time. I don't know what you're talking
Don't make
about.
that excuse. Exactly.
They don't need to be on nectar and puree. Just stop it. It's not the safest diet.
My gosh. Yeah, we see it. We see it all the time for sure. Oh my goodness.
Oh my God, yeah. What would you say one of the most crucial processes is? Would you say it's the development of the protocols, or kind of a combination between the education piece and how you use that to create a new protocol?
Yeah, I mean, it's tricky to pick one, and I've actually been asked this question before, and it was actually at a surgical conference. And I think the biggest game changer for both facilities was creating a post-op order set that involves speech. I think that a lot of your problems are solved when speech is already on the case. So like, we can provide education to our families and our patients and our nurses if we're just consulted on the trach patient, right? We can improve outcomes if we're just consulted on the patient. There's many facets and many educational tools that you can add to your trach team that is specific to your facility, whether it be an education brochure or a CEU like Cerner Epic kind of like course that you have to take when you like start working at your facility, like a mandatory CEU. You can create like badge buddies, or like there's so many things that you can do, signs for the wall. But I think if you don't get the consult, you don't know about the trach patient, and then there's nothing you can do. So I felt like that was the biggest game changer, is creating a post-op order set or a automatic speech order on trach patients. It also just takes a load off of the doctors and the surgeons, expecting them to consult you when they're ready for a dysphagia eval or communication eval. It's kind of like the patient's got a trach, speech is going to see them. There's things that we can't do and that we need help and assistance for, but then we can actually ask for those things. But we can't do that if we don't know that that trach patient even exists. So I feel like that's just been our game changer, and I'll advocate that. My whole career is post-op day one, get in there and just ride the wave of their trach journey, and maybe you need to sign off on them. Maybe you get the consult and they are just not appropriate. They're end of life, they're hospice, the trach was placed in a like heat of the moment to save them, but family has decided, comfort measures only, hospice. Then you could sign off. You tried, you did your due diligence, you got the consult. But I'm not saying that every trach patient is going to need and receive therapy. Using clinical judgment is obviously the common denominator. So
yeah, and I kind of thinking, because my brain's always crazy, but thinking about like how we worked with, like, our hospital was stroke certified, and so like you mentioned, the stroke order set included speech, things like readmission of patients who had pneumonia, whether it didn't necessarily have to be aspiration pneumonia and classified as such, but that 30-day readmission window, we get that automatic consult. Do you foresee that most facilities maybe have more of like a respiratory certification or a trach and vent certification in the future that maybe would help facilitate that? Or do you think it's always just going to be us advocating for being on that order set?
I mean, that would be fantastic. I've seen different facilities where like respiratory mans most of the trachs and vents, and then I've seen like some facilities where nursing is like the leaders in trachs, and it's quite shocking because I know they don't get the training that they need in school. But that would be, I mean, a brilliant idea to create. I know they have like the HCAP scores and like, and they have certain parameters, at least in our level 1 traumas, that are critical indicators, like readmission rate, like you said, or VAP, like ventilator acquired pneumonia, and community. So like you said, all the different kinds of pneumonias. And I know that they get dinged for, recurrence of a ventilator pneumonia. So it kind of starts making the wheels in your head start turning, like, well, if we can start getting them therapeutically receiving therapy, right? PT is a huge thing, mobilizing them, moving them, passive range of motion while they're intubated, right? The atrophy of muscles is the same in our throat and in our pharynx. If we can get, speech involved in implementing an inline passing mirror valve or an expiratory muscle strength training regimen, maybe we can see a reduction in those VAP scores or our reoccurrence in pneumonia scores. We've educated the patient from day one how to expectorate oral secretions versus just cramming them back down there and swallowing and creating another kind of pneumonia or mucus plug. So I would love to see that. I don't know how soon, maybe it might even be not even in my era of a speech language pathologist, but all we could do for now is advocate for our little trach patients.
Right.
Right.
I'm just looking in the chat. I don't see anything in the chat or the Q&A right now.
Okay.
So if anybody has things that they do want to ask, make sure you get that in there because we'll be wrapping up in the next couple of minutes. But yeah, this was really great. And I think just looking at all the areas, because again, we're looking at dysphagia primarily in communication, but then also voice becomes a big part of this as well, because we know that a lot of times when an anesthesiologist is the intubator, and not to pick on them because they're great at what they do, but there's a lot of times when, someone's being emergently intubated that they get injury to the one of the vocal folds or both of the vocal folds. And so that is impactful for voice and their ability later on to tolerate a speaking valve. And I think that's an important point to make too, because again, everything's connected. And if we can, if we can say that again to physicians and nurse practitioners, physician assistants, and other members of the team, then they're like, oh, that's why you should be involved.
Yeah.
It's like the light bulb goes off.
Yeah, like you may not change the way you're intubating people, and I might not be able to get you to do it more gently, but if you know what we do in our role, you might be more apt to consult us and let us do our thing, because you're like, uh-oh, that was an emergent intubation or a prolonged intubation or a recurrent intubation. Let's get speech on board because I know that they have the proper tools in their toolbox to optimize and help my patient, rather than, like you said, throw them on thickener or throw a tube feeding on them and no one assess the potential that they needed or could have been doing without our consult.
Yeah, for sure.
Absolutely.
No, this was excellent.
Okay,
I really enjoyed.
Yeah,
I really enjoyed having you on, and I just appreciate the knowledge about tracheostomy team development, because I think it's definitely a niche, but it's also something that I think more people could be involved with if they knew the steps that you mentioned, like having the quality improvement processes and being able to start a project or be a part of the project, because it does get us out there and it gets the consults too, but it also gets what we do and the value of what we bring to the table out there for other team members to realize, and also fosters our communities getting more education about our services as well.
Yep, absolutely. Absolutely. This was wonderful. Thank you for having me. I really enjoyed it.
You're welcome. Thanks for being here, Rachel. I appreciate you so much.
Thank you. Hopefully everyone enjoyed it. And if they have questions, they can reach out to me or they can follow me on Instagram or whatever. I answer all my emails and my messages. So
yeah, you do answer all your emails.
I do. And I do it fast. I try to do it fast. 24 hours is what I try to do. So
I try to do that too. It doesn't always work, but for the most part, it's helpful. Yeah. Well, thank you so much. And I hope you have a great rest of your evening.
Thank you so much. Bye.
Bye.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Each episode comes with an accompanying course on speechtherapypd.com. available for a 0.1 ASHA CEU. And just for our listeners, get $20 off any subscription with promo code BRAINSTORMS20. SpeechTherapyPD.com is run by SLPs for SLPs. We've got the largest library of ASHA CEU eligible courses out there, adding fresh content every week. Remember, use BRAINSTORMS20 to get $20 off access to over 1,000 courses for an entire year. Head over to SpeechTherapyPD.com for more information and start earning CEs today. Thanks for tuning in to Brainstorms, Functional Neuro Rehab for SLPs. And don't forget, SpeechTherapyPD.com is your go-to for all things ASHA CEUs. Your positive reviews and support mean the world to us. We'd love for you to drop us a quick review and hit that follow button.